to present post-operation of the first case. To remind you, the first case is keratoconus. Eye examination, left eye. Visual acuity is 20/50 with pinhole 20/40 -2. Cornea minus decimate 4. No epithelium defect. Anterior chamber deep, no cell. Lens phakic. This is the picture of the patient. Diffuse beam. The next picture is anterior OCT.
Dr. Fogla, would you like to tell us about the post-operative regimen in your talk?
Yeah, maybe I'll show the slide and then explain what. Yeah.
Okay, ma'am.
So it's nice because it's the patient's own endothelium. You can see that the cornea looks very clear because it's the healthy endothelium that's working already.
Okay.
And this is what makes it very exciting because if you have a patient who sees like 20/50 or 20/40 the first day, obviously they would want the other eye also to be done very fast because being a keratoconus patient, especially suddenly they feel that the other eye vision has gone worse. So they come and say, ever since you did surgery on this eye, I'm not seeing very well with the other eye.
So Mel will do the other eye surgery very soon.
You have to be here again. Any special thing that we have to look for at the post of day 1?
Yes. What would you look at on post of day 1?
No, these are patients where we start them, they're young patients, and we start them on steroids too early on the first day. But the next day when we see the patient, one thing is the intraocular pressure, because sometimes you have some patients who are steroid responders. Yeah, so the pressure can suddenly shoot up, so you have to, because patient we see on day 1 looking fine, so we assume that everything is going to be fine, so we keep a close watch on the intraocular pressure. And the second thing we would like to look out for is the epithelial healing. That's basically the same thing what you do in every graft, but those are the two main points that we look out for in these kind of patients. And if I feel that the surface is not healing very well, then we can sometimes put bandage contact lens for some time. Or if you have a patient who's not going to be under my care, I don't like to put a lens and send the patient away because of fear of some secondary infection. So then I would add a nighttime ointment application to the eye.
Do you usually put the contact lens if you know the graft is like have 100% epithelial defect?
No, usually most of the grafts that we get, the epithelium is already kind of it's broken. It's because these are not the best of quality tissues that
Right.
you get.
You
So
have to
there is a little
slough
bit of
out
epithelial
anyway.
sloughing. So what I do is I usually debride the whole epithelium at the end of surgery because I want to do the keratoscopy. So if I have bits and
Yes,
pieces
you
of
have to-
epithelium, you cannot see the reflex. So I will debride all the unhealthy epithelium. And these are patients with very healthy limbus. So you will have the sheet of, within 3 days, the reepithelialization is complete. But if you have patients who have significant history of vernal conjunctivitis in the past, sometimes their limbus has something like a partial limbal stem cell deficiency. So in those eyes, maybe either you request for a tissue that already has good epithelium on it, or if that is not there, then you need to watch out for the rate of epithelial healing in the post-op period.
I see.
In some patients, I also, young patients with advanced keratoconus, history of allergy, I would give a supratarsal steroid at the end of surgery, usually dexamethasone, so that it kind of helps the control of the surface inflammation immediate post-op. Otherwise, if they have to put frequent drops, the drug toxicity also affects the ocular surface.
See. And how frequent do you see early Savalia in post doc? Have you ever seen that? I have seen one.
I haven't
one
seen any
after
of
doc.
my patients because the only way to prevent urate Zavalia is to be be aware about it. And if I put an air bubble in the anterior chamber, let's say I have a small perforation and I know that at the end of surgery I'm going to put an air bubble, I will ask my nurse, the nursing staff, to put a dilatation drop in the eye intraoperatively so that by the time I'm finishing surgery, my pupil is already dilated. So that if I put an air bubble, you don't have a problem of having a
And you don't
pupillary
need
block.
the PI.
Yeah, then you don't need the PI. But then again, you have to have frequent post-op because you need to have another drop because this pupil is going to constrict again.
Right,
So you have to be aware of it. You cannot send the, most of the time people who do have this kind of problem are usually patients where you put an air bubble and you send the patient away and you want to see the patient 3 or 4 days later. So if I put an air bubble, I will see the patient every day till I'm sure that the bubble size has decreased and the risk of pupillary block is not there. And if post-op, if I do see them 2 hours later on slit lamp and if I feel the pressure is a little high, I will go through the side port and I will release some air on slit lamp just to ensure that the IOP is normal.
Thank you. So we can go ahead presenting the live surgery cases.
Okay, the first case is the 47 years old Thai male with type 2 diabetes and hypertension. He was diagnosed as lattice corneal dystrophy both eyes. The uncorrected visual acuity is 2500, 2800 with not improved after correcting. And today we plan to do the DALK of his left eye. This is the picture of his right eye. You can see the small refractive line in the central and paracentral area. This is the left eye, the eye of the surgery today. You can see the refractive and the ovoid subepithelial lesion. And this eye, the endothelium look thicker than the other eyes. Okay, so we decided to do the further investigation, include the confocal microscopy of this patient. This is for the right eye. And the left eye, you can see the dermal, but exceptional, the dimness area of 597 micrometers. And this is the anterior segment OCT of the patient, the horizontal cut of the left eye. And the dimness area of 564. This is the confocal microscopy and the endothelial cell count was done. His endothelial cell count is 1985 cell per millimeter square and measure area is 508 and the hexagonal is 39.5%.
Okay, the patient is waiting for you. Yeah, you just show the slit lamp picture. So maybe you would tell your plan for today's surgery.
No, this patient, we will try and do a big bubble DALK. And on yesterday when I examined the patient on slit lamp, the corneal thickness looked a little thicker than usual normal. That's why we asked for the pachymetry. There were a few folds in the decimus as well, so a specular was asked for. The confocal shows a cell count of 1985 cells per millimeter square, which is maybe slightly less for his age, but I think that a DALK would be ideal in this situation. And he does have some nuclear sclerosis as well, so once the DALK is done, maybe later on he would require a cataract surgery. So I think in this situation with the this kind of cell count, even a cataract surgery would be safe for him, rather than doing a triple procedure like a PK, ECC, IOL. In lattice dystrophy, usually we don't expect any other problems, unlike macular corneal dystrophy. So I think the surgery should be fairly straightforward, and let's see how it goes. The size of the trifine, what I would choose in this is about 8 millimeter, which is the standard that I choose, but the donor we can oversize by 0.5, so the donor would be 8.5. And maybe in the presentation that I'm going to show today, maybe we'll show you again a failed big bubble, how you do a manual. So in case if I don't get a big bubble, then we'll do a manual technique in this case.
How long will you wait for cataract surgery?
For cataract surgery, usually, ideally, you would wait till the sutures are removed and the topography is stable. But a lot of time, these are patients where you do one surgery and they come back and you ask them, how are you doing? They say, not good, because I can't see very clear because of the cataract. So then you have to fall back on your usual cases, like an average K that you take for your post-keratoplasty patient. I take something like 42 or 43, and I would take that average K and go ahead and do the cataract surgery. And later on, if there is a significant refractive error, we can always look at the other options of doing a surface ablation, or in India nowadays, Reina makes these sulcoflex lenses, so you can think about doing a toric sulcoflex lens for, if he has a residual power significant enough post-suture removal, you can go back and do a secondary procedure to put another lens in the sulcus to correct that.
And this is second case, 19 years old male, no underlying disease, and his pre-existing ocular disease is allergic conjunctivitis. And this diagnosis is keratoconus both eyes. In this case, he tried to fitting C out but failed due to unstable RGP both eyes. And his uncorrected VA is cut the finger to feet both eyes, and best corrected VA is cut the finger to feet. And yes. And this is right eye's picture. There is a superficial scar, and we see the work striae on the right eyes. And this is left eyes. He has a deep scar. He had a deep scar because of he had corneal hydro. Around 9 months.
9 months.
Yes. And this is topo. Yeah, and on the right eyes. And this left eye that we plan to do DALK. And K1. On K1 is around 52, and K2 is around 60, and K average is around 60. Yeah. And the contact thickness is 462. This is atria segment OCT.
you just give any idea about the size from the topography, the size of
The size of
trephination?
the trephination would be a little larger, maybe 8.5 is what I'm going to choose. So if you see maybe around the 8 millimeter zone, it's about all in the range of 500, 522, 515. So I think I'll just go about 8.5, should be okay. If you have 8.75, maybe that's even better, depending on what's the availability of the suction trephine in the OR.
But it's gonna be the same size, right?
Yeah, same size donor, yeah. And yeah, this will be a manual DALK, so no big bubble in this situation. So the key factor in this is to try and do a good trephination, almost up to 90% depth, and then you create a plane at that depth, and you carry the plane 360 degree, and the center part you just peel. So what happens is, what is peripheral to 90%, when you come to the apex, it's already very thin. So if you do a post-op OCT, you will see some amount of residual stroma in the periphery, but when you try to come to the apex, you will be almost like
Maybe
very
you
close to
can
the
show that
decimates.
intraoperatively.
Maybe, yeah,
Yes.
that's what we are planning to do today. So even after trephination, we can use the OCT to see whether
how
we have
deep.
achieved the
Yes.
right depth or whether we still need to go deeper. At the site of trephination, what is not at the apex. So if I'm going to trephine at 8.5 on the pachymetric map, you see the thinnest point. So if the thinnest point is 520, then you would go 90% of that. So maybe around 470 or 480 is what you would plan to cut down to.
ก็คือมุมเนี้ย
And if you use a femto, we always use a safety margin of 100 microns. I have used a safety margin of 50 microns, and I've had a through and through with the femto cut.
But let's say if for beginners, if they had already made the trephination, but it's true and true.
Yeah, that's what I'm going to show in the video. That if
Okay.
you have through and through, what can you? Because it
Yes.
has happened to me. Because sometimes you have asymmetric thickness across the cornea, and you look at it and you think that, okay, this is fine. Maybe in my hands it may not happen, and you go one more turn, and then you realize there's fluid coming everywhere, and then you realize that. So I'll show a video where maybe for 3 or 4 clock hours we has gone through and through. So we still go ahead and do the DALK.
So trephination should be made really slowly in
Yes,
keratoconus
maybe, yes. It should be, and always it's better to be,
to detect if there is any perforation.
to be 1 quadrant less than what you intended.
Okay, so next is the talk from you.
So let's make this an interactive talk, because no fun me going on and on. So I guess maybe I'll try and see. I'll ask questions.
So it's about the complication and management.
Complication, maybe I'll just do a quick recap of what we did yesterday, so that there are a few things that I missed out yesterday. I'll try and show that as well. The post-op medications that we use post-DALK, usually I would start the patient on topical steroid, usually prednisolone, or you can use Tobradex. We give them, the first week after post-op is usually too early, steroids, but within a week we bring it down to 4 times a day, and then over a period of next 3 weeks we taper it down. So after a month they are usually on softer steroids like fluorometholone or lotepred. The only thing would be young patients or patients who have history of active vernal conjunctivitis. So these are the patients where we continue with full-strength steroids for a longer period of time, because we have found that if you switch them over to softer steroids, the disease becomes more active and the sutures tend to become loose much faster, and sometimes they can also experience something like a stromal rejection. So this subset of patients, we keep them on full-strength steroids for at least 6 months. or till the sutures are removed. Lubricants are very important. You try and give lubricants 4 to 6 times a day, and with some nighttime lubricant gel application. Besides that, you have to watch out for the rise in intraocular pressure, and if you have patients who are steroid responders, because some of them will have past history of being treated for vernal, and they have history that when they have been using steroids, the pressure goes up, so you try and then see what are the other medications. So in India, we do have this topical tacrolimus that's available. So we use tacrolimus ointment application twice a day, and that we find is like steroid sparing. Or you can use topical cyclosporine as well. And that too, not immediate post-op, but we initially manage with the steroids. But then once the initial post-op reactions are quiet, then we switch them over to something like cyclosporine. But we also add topical fluorometholone along with the cyclosporine, because cyclosporine per se cannot control the inflammation. Avoid using NSAIDs, because NSAIDs are not very friendly to the epithelium. So topical NSAIDs, because some people do think using as a steroid sparing agent, but I don't like topical NSAIDs for my post-keratoplasty grafts. Oral steroids, yes, sometimes we use in patients who have a compromised ocular surface where you want to minimize the use of topical medications and steroid responders, and people with young children with very active vernal disease. So we sometimes give them a short course of oral steroids, which helps over initial post-op problems. And if I'm doing a patient with a compromised limbus, sometimes I will combine my DALK along with the amniotic membrane transplant. So I will do my DALK. At the end of DALK, I will put a amniotic membrane over the cornea and do a purse string suture to secure the amniotic. I don't use fibrin glue for the amniotic membrane, and then put a bandage contact lens. So the amniotic membrane ensures that the epithelial healing is good. Because sometimes you may do a beautiful DALK, and if your patient has a persistent epithelial defect which does not heal for a long time, you will realize that the cornea becomes hazy, and then you end up with a problem. For ensuring good tear film, temporary punctal occlusion can sometimes be considered. We do put collagen plugs in the punctum when you feel that the epithelium is not very strong. So I think some of these points are pretty similar to what you would do in a post-op penetrating keratoplasty as well, in terms of trying to get the surface to heal. So do you use cyclosporine or tacrolimus in your practice for post-keratoplasty?
We don't have tacrolimus here.
You do have tacrolimus, I'm pretty sure, here. So in India, what we do is, we have now Oralab that manufactures tacrolimus for the eye. It's called Tacliment. But if you don't have access to the tacrolimus eye ointment, we use the tacrolimus skin ointment, but it's not applied into the eye. We have the patient apply it over the eyelids, and you will find that it's been described. Mm-hmm. And if you apply the tacrolimus ointment over the skin, it penetrates and gives the effect in the eye. So it's come as a 0.03% tacrolimus skin ointment, so you can try using them for your patient. And no, it's not toxic. Mm-hmm. And this is very good for patients, especially with chronic vernal catarrh, mm-hmm. where you feel like you can't use them. So just using a nighttime application of tacrolimus can really make a difference.
I see.
Just on the eye.
On the skin only.
Into the eye, or you just want
I've
penetrate to
had some patients who, despite being told to put on the eyelid, have accidentally put it in the eye. Besides causing a little bit of irritation, it has not caused anything, but it's not recommended. But if your patient applies it, they don't have to apply a huge amount so they can rub the ointment on their finger, and then they can gently apply on the eyelid, and that penetrates through the skin to give the effect on the eye.
So what would you prefer if you have both? Because cyclosporine is kind of, irritating.
Right now, with the experience that we have, we feel our patients are much more comfortable with tacrolimus. The only concern with tacrolimus is there is a paper with the long-term use of tacrolimus of ocular surface malignancy developing, but that again is something which is not, the cause and effect relationship has not yet been established. That's just an observation.
Because I saw one patient which is vernal, and I applied the topical cyclosporine, and the there is
Depigmentation.
skin, yes,
Yeah,
depigmentation.
that happens. Even with restasis, people using long-term restasis, sometimes they get
Yes.
depigmentation of the
Yes.
skin. That again is one of the side effects of cyclosporine.
Okay.
Actually, I had experience using tacrolimus not skin cream into the eye. I use it with my actually I'm using with my chronic allergy VKC.
Yes.
Even in the children, I use it with about 9 to 10 years old, and they did very well with 0.03%.
Yes.
They don't even complain. At the beginning, I told them if it irritated or it get toxic or you can't tolerate it, you can just stop it. None of them stop it.
Yes.
So now,
So I think it's
I use it
important that
inside.
besides just thinking about the
put-
vernal catarrh patients, even in post-keratoplasty patients, it's a very effective drug. So a lot of my patients post-keratoplasty who are out 2 years, 3 years follow-up, sometimes when they have an episode of rejection and cyclosporine is very difficult to find, we put them on nighttime tacrolimus application and they find that they are very compliant and it doesn't cost too much. It's not a very expensive medication. It's much better than giving them oral immunosuppressives, which again they have to do periodic blood tests and all those things, so you don't need to do that.
But I just wonder how can it penetrate through the thick eyelid and into the eye?
Well, that again we have to look at the pharmacokinetics of it, but it does penetrate. So the effect is not exactly into the eye. The effect is on the ocular surface. So I think it's some way it gets absorbed by the skin and it gets in the blood, and that's how it comes. Maybe it's some part of it comes in the tear.
But it's quite costly in Thailand.
The tacrolimus,
Expensive.
not the oral tacrolimus. This is a skin ointment. Skin ointment is not very expensive. The oral tacrolimus that you take. Okay. But in India, if you look at it, the one from Oralab, the tacrolimus ointment which you have, it costs only about $2. Yes.
I want to confirm the point that Dr. Varinton said that she used the skin cream inside the eye,
Okay,
not
that's what
over
I'm
the
saying.
eyelid.
That's what I'm saying, that I have had patients where they have been instructed to apply on the eye, and when they come back for follow-up and I ask them, they say, no, I have been putting inside the eye and it irritates. So that's it's not caused. So, but since it is mentioned in the skin cream that it's for external application, we advise the patient not to apply in the eye. Tomorrow, if you have an adverse reaction, you can come and sue me that you gave me a skin ointment
to
apply
avoid the
into
lawsuit.
eye. Yes.
Try to be careful. Yeah, but it's not recommended actually because because my patient is very trust on me and
Yeah.
they are my patient for a long time with
But I think that
raise them up and since the
tacrolimus is
childhood
really,
until
really a good drug,
Yep.
and you should.
Let me ask the audience, whoever used this kind of regimen, because I've never used that. Anybody, just raise your hand. No? Okay, but this is, just Varinton and Fogla and Rajesh.
No, this is
Okay, this is-
worldwide. A lot of people are using it, and I'm just
Yes,
trying to
yes.
update you on this. That
But this
this is something which was grossly underutilized, and
Yeah.
since we have now, Oralab has started manufacturing this ointment in India, but between corneal surgeons now, it's especially the young corneal surgeons, everybody uses tacrolimus, and I have finding it. Instead of just thinking about chronic VKC patients where to use, I've started actively using in my keratoplasty cases, and I think they do much better, and the steroid-induced complications of IOP rise and cataract can be minimized. And plus, since it's an ointment based and you apply at night, it helps the epithelium as well in terms of if there are any dryness in the eye. So looking at, just to give you an indication of my practice, I see a lot of keratoconus patients. Sometimes in a day, I would see 8 to 10 new keratoconus patients. And most of them are advanced, so they're all referred for maybe surgical intervention. So when we analyzed our last series between 2006 and 2011, out of 450 eyes, 382, that means almost 84%, 85% were keratoconus. Corneal scars were only 8% and dystrophies were only 7.2%. We were able to achieve the big bubble in 92% eyes. The remaining we did maximum depth DALK. And average post-op vision was about 20/60 uncorrected and improving best corrected to 20/30 or 6/9. The astigmatism varied from 0.75 to 9 diopters, and the average cell count was about 2,800. Complications, yes, they do happen. Microperforations in about 38 eyes, 8.4%. So almost a 10% microperforation rate, depending on the kind of cases that you choose. Out of the 38, 15 eyes, almost one-third of them required air injection to settle the detachment, because we did get a double anterior chamber. Type 2 bubble was seen in 4% of the eyes. Resuturing, we had to go back and do in 4.8%, because some of these patients, the sutures can become loose very fast post-operatively, especially the patients with active VKC. So you need, when they come back for a follow-up at 1 month, if you see a loose suture, it's too early to remove that suture, even if they are all interrupted. I would go back and remove the loose suture and put it up. Because if you remove the suture, what will happen is you will get what is called as a microdehiscence of the graft. And later on, you will have that as a weak area. And when you remove the remaining sutures, this area will start bulging out. So I always go back and place. Or the other reason for resuturing will be when a patient comes back at 1 month and I look at the patient and I find very high astigmatism, and I realize that maybe there are some sutures which are very tight, which I did not recognize immediate post-op. Then I would go back and remove the tight suture and replace them. Because if I don't do it at that point of time, the wound healing will happen in that pattern. And later on, even when you remove the sutures, you will not get the desired effect. So I think the first 1 to 3 months is a time where you can go and revise your sutures to ensure that your outcome is good. Because if you do a beautiful DALK surgery and if your suturing is not perfect, you will never have a satisfied patient, because if they have a huge amount of astigmatism, they still can't see very well. We had interface vascular stromal rejection in about 3.6%. Again, these were the patients where we stopped the steroids or reduced them, brought them up to softer steroids much quicker. So now we have identified, we know which group of patients they are more likely to have inflammation, so we kind of keep them on full-strength steroids for a longer period of time, especially children. And interface vascularization occurred in about 1.3%, and these were basically in patients who had loose or broken sutures and they did not seek any medical advice. They just, because they could see well, they just waited, and that resulted in blood vessels creeping into, because the interface is a potential space, and if they come to the graft source junction, and from there you will find the blood vessels can easily find their way into the interface. We have done laser refractive correction in about 48 eyes, and this was 3 months after the complete suture removal, and they had a stable corneal topography. We have also done quite a number of phakic IOLs in patients with significant refractive error post-DALK. And these are all possible because the anterior chamber depth is adequate and they have a good cell count. So doing a LASIK is also quite comfortable if you use the femtolasic, and even if your cut goes across the graft junction, it's not a problem. We have used the microkeratome as well, but some people feel scared to use the microkeratome because they feel with the vacuum and everything whether the graft source junction will be secure. But you can safely go ahead and do that. That's not a problem. You can do a surface ablation, but the only problem with surface ablation is you'll have to use topical mitomycin C, because if not, these patients tend to develop the incidence of haze formation is quite a bit in these eyes. And putting a toric ICL is quite good because the range has been extended. So if a patient is an eligible candidate for a phakic IOL, I would prefer the phakic IOL over the laser refractive surgery. This we have already seen post cross-linking haze, the surgery that we do. Let me just take you over to, that's a patient with blue sclera and keratoglobus, and that's how the cornea looks. You can see. So in this patient, I don't know. Yeah, maybe I'll play the video separately. So this patient, we did not a DALK, we did an epikeratoplasty. So what we basically did was, maybe I'll locate the video and play it. What we did was we did a peritomy 360 degree, and then we removed the entire epithelium using an alcohol swab. We made sure there is no epithelium left. Took a donor tissue and trimmed out up to 1 millimeter of the, so it had 1 millimeter of scleral rim all around. Then we removed the decimates from the donor, and then we placed the tissue over the cornea and secured it to the episclera, and then sutured the conjunctiva back. So that's what it looked like at the end of surgery from that. And that's how, if you see the slit view, it looks like a dissect, you know. So the lower part is the patient's own cornea, so you can see how thin the cornea was. So we placed, so that's how it looked on day one. You can see the patient's own decimus, which was already detached and torn, so you could not repair that. So we placed that's like an epikeratoplasty that was done. And then later on, 3 months later, we went back and did a central PKP. And so because now the thickness was adequate and we could do a central PKP and she had good vision. The other eye was already lost because of trauma, because of the blue scleras he had ruptured. And that's another patient. You can see how thin the cornea is. Again, similar situation, but here the cornea was clear. There was no DM detachment. So we did a similar procedure on her, epikeratoplasty, using a donor tissue. That's how she looked post-op. And you can see that she has now finished about 6 years of follow-up. And you can see the fellow eye, which is already, because somebody had done a PKP in that eye and then she developed glaucoma and then it's bulging. Whereas this eye, if you see with the epikeratoplasty, when we do a peritomy, we try and get the palisades into the conjunctiva. So the limbal stem cells we try to harvest along with the conjunctiva so that when you put your conjunctiva back, you don't have a limbal deficiency. So you can see that she is doing well. She is. So let me just go back to my other. I've been going back and forth from different presentations. So when we spoke about the Dua's layer, how many of you understood what Dua's layer? It's clear in the audience? No response. So let me try and see, because it's important, so you should understand what we are talking about. So when we create a big bubble, we were always thinking that the separation is between the decimets and the stroma. And this went on for several years, and all my presentations that I gave, I always went on saying that a type 1 bubble is something between the stroma and the decimets, and a type 2 bubble is a split in the decimets. So you have the banded, non-banded portion of the decimets, and a type 2 bubble splits that. And so everybody was happy with that till the Professor Dua came and changed part of that. So he did some experiments and showed that when you do a type 1 bubble, after you get the bubble, you can peel the decimets off and the bubble doesn't disappear. So which means that the bubble does not form between the stroma and the decimets. So there is a layer that is called as the pre-decimets layer between the stroma and the decimets, and the separation in the type 1 bubble happens between the stroma and the pre-decimets layer. Now whether the pre-decimets layer is a part of the stroma or whether it's a separate layer is something which is controversial. So when you inject air, and what we have been seeing yesterday, the type 1 bubble is something that you see a separation between the stroma and the pre-decimets layer. And the separation, the peripheral part, you see these fibers which are separating. These are basically stromal fibers which are separating, and as air enters these stromal fibers, you get the dense white border, what you see there. Whereas a type 2 bubble is something that's seen between the decimets and the pre-decimets layer. So basically between the stroma and the decimets. And because there are no stromal fibers between the decimets and the stroma, that's why in the edge you don't see any whitening effect. What you see is a very clear margin as what you will see there. So that's because its separation is occurring between the decimets and the stroma. So we discussed that what are the indications we can do for all ectatic disorders, including keratoconus, post-classic ectasia, pellucid marginal degeneration. Keratoglobus is difficult to do DALK because the cornea is thin from limbus to limbus, so you don't have a base where you can suture. So that's why I prefer doing an epikeratoplasty for keratoglobus. Stromal dystrophy you can do for granular, for lattice, it's good, but for macular, you have to be careful what you talk to your patient, because the chances of having a complication is much higher. You can do it for all corneal scars that do not involve the decimets. If you cannot see behind the scar, always plan a manual DALK, because what you cannot see, if you blindly try to inject air, they're more likely to end up with complication. Avoid big bubble in very advanced keratoconus because the decimets is already, or the pre-decimets layer is already very much stretched. And if you try to inject air to create the big bubble, this layer gets stretched even more. So just like you get a high drops, what will happen is the bubble will start forming, but once it forms a little bit, you will find that it suddenly gives way. Extreme thinning and any scars involving the decimets. So we spoke about pre-op evaluation. We spoke about the anterior segment OCT, the importance of it, the regional pachymetry. We spoke about the trifines, what we used yesterday during surgery, that's the Hesberg-Barron suction trifine. we are familiar with the femtosecond laser that you can use to make a cut, but with the femtosecond laser, the safety margin that you set from the pachymetry has to be a minimum of 100 microns. If you try going lower than that, chances are that sometimes you may end up with a through and through cut. The other trifines that you can use, this is a very nice trifine, it's from Moria. So this is a suction trifine, same as Hesburgh-Barron. The advantage of this trifine is that it has a system whereby you can preset the depth in the suction trifine. So these marks what you have, this is 200, 250, 300, 350. So this is a slot again, so it's kept here, so it will cut up to 350. That means once you set it at 350 and then you apply the suction and you make the turns, you don't need to remember how many turns to make. You make the turns and it will go to 350 and it will stop. It won't go beyond that. So that's the advantage, just that it is more expensive. An average, this trifine costs about $60 to $70 for one trifine. This one will cost you about $120 for one trifine. This is again another very nice trifine. This is available from Coronet. It's a UK company. And these are preset depth trifines. So you have a trifine where the blade is set for 300, 350 or 400 microns, and this is a free handheld trifine. So if you don't want to use a suction trifine, you're more familiar with your handheld trifine, you can order one of these trifines, preset depth trifine, and you can go down and you can use them for your surgery. And that's the micrometer knife that we spoke about. We spoke about the advantages of debulking, different cannulas. We make a small track and advance the cannula. Somebody was asking me, oh, you have to put it centrally. No, you don't have to put it centrally all the time. If your apex is not very thin, you can go center, but here you can see I'm going paracentral. So if you have a thinning here, you can sometimes go away from the thinning. If you try to go towards the thinning, you can sometimes end up perforating. You inject air. Once you see the bubble, so basically when you inject air, you will see three phases. The first phase is your air in the syringe will get compressed and your bubble is not yet formed, so you will feel some resistance. And so you keep injecting forcefully till you start seeing the formation of air, whitening at the tip, and then you keep injecting force. Don't stop, because sometimes because you're hesitant that you lose, your stroma becomes loose and further air injection just spreads laterally. So you continue forceful injection till that whitening, and suddenly you will feel a give way sensation and your bubble will form. Once the bubble forms, you can even stop. There is no need for you to continue injecting. So you can, and then you can inject air in a controlled manner to expand the bubble. And when the bubble expands, you will find that after some time, the resistance increases again in the syringe. And that's because the aqueous has no place to get displaced. And the eye pressure will become very high because the bubble is forming, the decimus is getting pushed behind, and the aqueous cannot go anywhere. So there, if you try to continue injecting, what will happen is because of the increase, because there is no place for the bubble to expand, and you are increasing the air pressure within the bubble. And then when the air pressure reaches a certain limit, the bubble will burst. So what I do is, at that point, if you want, you can make a paracentesis to release some fluid so that the counter pressure is reduced. And then in a controlled manner, if you inject air, you will find that you can enlarge the bubble to the desired size. Usually I don't try to go beyond 8, 8.5, but at that point you can stop, come out. But without doing a paracentesis, if you feel resistance and you continue injecting, the chances of the bubble rupturing are much higher. One hand. But I stabilize with my other hand, the syringe. So just see this. I'm injecting, and then. So if you see here, everything is going fine. If you see in this video, sorry. So that's the point. You feel that it's just reached there, and you're feeling significant resistance, but you want to try your luck, you can end up with that. So what I do is, when I'm doing my surgery, I will hold the syringe like a pen. I will use my left hand to, I hold the syringe like a pen, and I'll use the left hand to stabilize the stroma, and I introduce the cannula in a very controlled manner. So I don't try to hold it like a plunger and then try to introduce it. That's very difficult. So hold it like a pen, introduce it, and then follow the curve of the cornea. If you don't do that, you will end up entering into. Once it has reached the desired position, I give this instrument back to the nurse. I come back with the left hand, I stabilize the syringe, give the right hand, it comes up, and then you start injecting. So your syringe has to be stable. If it is not stable, what will happen is the movement of the cannula will widen the track, and then when you inject air, the air starts coming out. Paracentesis, usually once I get the bubble, I do my paracentesis. Yesterday, I did the paracentesis because the eye pressure was already feeling a little firm. So when I injected air, I realized that, so I can leave my hand from the plunger, keep it stable with the other hand. I take the 15-degree knife and I go make a paracentesis, come back, and I inject again. But if you want, you can even withdraw, come back, do a paracentesis, take the syringe again, go back into the same track and inject. That should be fine. If for some reason, if the track becomes a little wide, what you can do is you can hydrate the track. That means take a BSS syringe with a cannula, put the cannula into the track and just hydrate. So what happens is when you hydrate the stroma, the track will become more compact. So then if you put your air injection cannula, the air will not leak out. So we saw a bubble deflation technique. You put visco and you can do that. This is something to show you. I've injected air and you can see all the air is going through the trabecular meshwork into the anterior chamber and all these fish eggs in the anterior chamber. And then I go back into the same track and I inject viscoelastic. I have another cannula from Bausch & Lomb, which is a 25 gauge cannula. So it's not a 27. 27 is for the air. The 25 gauge cannula is for the visco. It has a bottom port. So you can use that cannula. So because it's 25 gauge, it's a little broader, so it fits into the track. And you can go back and put cohesive viscoelastic, and you can, when you fail with air, you can do with visco. But the only problem with visco is sometimes the viscoelastic injection can create a pseudo bubble. That means you can get a visco bubble, but that's not between the predecimus layer and the stroma. It will be in the deeper layers of the stroma, so that when you open it up and you try to see, you will find that there is significant amount of residual stroma still left behind. This one? No, there was. I'll just play it again. So there is no rupture. It's the air is coming out. If you see, it's coming out from the trabecular meshwork. If you follow the video, it's coming out from, the air is going from here into the anterior chamber. So the air goes laterally and then it goes through the trabecular meshwork. So there is no rupture. That's why, because it goes through the trabecular meshwork, you get the multiple bubbles kind of thing. You don't get one bubble. So you excise the residual stroma. So this is another case where I'm doing a planned visco bubble. So I'm not injecting air. This is a post cross-link tie, and I realize that in post cross-link tie, if I inject air, it is sometimes very difficult to get a bubble because the corneal lamellae are more compact. So to do a visco bubble, the technique is slightly different. Because viscoelastic is more dense, it needs a softer eye for the visco bubble to form. So if you want to do a visco bubble, I make a paracentesis, I release the aqueous, I put an air bubble in the anterior chamber. So now this eye is not very firm, it's a little softer eye. I make a track at about 90% depth, go with my cannula, and you can see that I put it there, and as I inject viscoelastic, you will see the formation of the visco bubble, which is pretty similar to like what you see with the, you can see that now. So that's the visco bubble that's forming, and the air in the anterior chamber goes to the periphery. So this is another technique, but this will have its own learning curve. So just like you become comfortable with air injection, if you try visco bubble, it will take you some practice to be able to get that. So this is again something which is quite useful, and but for you, if you have a failed bubble, before you give up, I think you can always try a visco bubble.
Excuse me, for the visco bubble.
Yes.
You say that you do the paracentesis.
Yes,
first,
we do a
and then
paracentesis.
you create the track. And
Yes,
in that situation, I think the eye is soft.
It shouldn't be that soft that you make it difficult to make a track. So what sometimes you can do is you can make the track, then make the paracentesis, release, make the eye soft, then put your cannula, visco cannula into the track. Because if your eye is firm, the viscoelastic is not able to push the layer back, so it needs a softer eye. So that's again a case where we have done air injection and we have failed. So now I have gone to the periphery. I make a small tract using the crescent. And then that's the stromal spreader. That's a new forceps which will be available very soon from stores. So you can put this stromal spreader into the peripheral pocket and you can create that tract all the way around. So you can see that. So it's a reverse action forceps. When you press it, the two limbs open up. These two limbs are blunt tipped and they can be introduced, so the risk of perforation of the posterior layer is minimized. So you can see that we put the tip into this pocket and then as you open it up, it opens up the stroma. And now we can use the Malbrand's peeling technique. You see that? You don't even need to dissect. So if you are at the right depth, if once you see this, you know that you are deep enough. You don't need to do any more dissection. So in this case, although we had a failed big bubble, we could still go pretty deep, like near decimates, and that we have seen yesterday, the use of the dissector. So basically, pre-op clinical evaluation, case selection, surgical planning is very essential prior to DALK. Bearing of the pre-decimus layer can be achieved consistently if you select your cases properly, and it is not essential to bear the pre-decimus layer in all cases of DALK. And I'm sure with the surgical steps that we have shown, definitely it will improve your success rate and minimize complications. Just to give you some point about, because you have a shortage of donor tissues, you should look at using vision graft. And very soon vision graft will be introduced in Southeast Asia, including India, and they are saying that the price of this tissue, they will bring it down to about $200. So if they bring it down to $200, that would be really great, because these are gamma irradiated tissues and they are stored in albumin. And you can store them at room temperature for up to 2 years. So you can just have them lying in your office, and whenever your patient comes for a surgery, you can use them. And they can be used for anterior lamellar, for therapeutic, even for your keratoprosthesis, managing corneal perforation melts. So this is very useful. This is on their website. It's called visiongraft.org. So you can go and look up more details. And just to show you, I have used 6 of them over the past 2 years, and they have given me good results. So that's how the tissue looks once you remove it from the vial. And then you wash it with BSS, and you can see that it looks like a normal cornea. And so you punch out and you can use it for a DALK. So it looks and feels like, it's not like a glycerin preserve where the tissue is, different consistency. This is pretty much like a normal corneal consistency, and just that the epithelialization takes a little longer compared to normal corneas where they epithelialize in 3 days. This may take up to 6 to 7 days. And the tissue may have a little bit of a haze when you see in the early post-op, because there are no keratocytes or nothing in the stroma. This is just collagen. So maybe it will take a while for the keratocytes to repopulate. So, but in terms of visual outcome, the visual outcome is comparable to fresh corneas that you use. Storage, again, this is something we have in India. We are fortunate because Optisol is very expensive. It costs almost like $120 to $150 per vial. So we do have Cornisol, which is manufactured by Orolab, the same components as Optisol, and it costs only $20. So I store all my tissues in Cornisol, and I can keep them for 2 weeks. So it's from India? Yes, from Orolab. So you can go to their website, orolab.com, and they manufacture Cornisol, and I store all my tissues in Cornisol now, and it's only $20. And I've used the tissue on the 14th day of preservation, and the cell count is excellent. It's been maintained, does very well. The same Orolab manufactures cyclosporine 2%. You know that when you have to use cyclosporine 2%, it's not a commercially available drop. You always have to compound it in your pharmacy. But they make the cyclosporine 2%. So if you want to have 2% cyclosporine, you can order that from Orolab as well. They also make voriconazole for us. It's called Vozol. So that's again something we don't have to compound from the IV preparation. So you have the eye drops available, voriconazole. And that's the tacrolimus, the tacrolimus ointment 0.03. So that's again, it's only about, like I said, it's only about $2. Very cheap, yeah. So we can use them for our patients. Even the cyclosporin, what you see is about $5. So it's very convenient for our patient, rather than have them buy the oral or the IV preparation of cyclosporin, which is very expensive, and then prepare a drop. And a lot of times, you're worried about contamination. So this one comes as an individual thing, you don't have to worry about that. Just to remind you about the meeting we have this year, 15th, 16th, 17th of December. And this is in a beautiful town called Lavasa. So you can see it has a nice canals and a huge lake. And it's a nice place. You can go to our website, corneasocietyindia.org. It's a 3-day meeting. And the first day we have a lot of basic courses, about 11 of them, including DALK, DISEC, and DIMEC. I do conduct courses back at my clinic at Apollo Hospitals 4 times a year. So more information you can email me. So this is on DALK and DISEC, and that's again a 2-day DIMEC training course as well. So let's come back to complications. I think so we can move ahead to complications? Okay. So this is the video. You can see that happily trephining. Maybe I missed the count, and you can see there's a lot of fluid coming out. And I had a full, this is a very thin cornea. You can see that. Normally you would think that the inferior part of the cornea is the thinnest, but here there was some superior thinning as well. So I got a full thickness trephination going almost from here to here. So I put 5 sutures to close that, put an air bubble in the anterior chamber, and I sat temporarily and I started dissecting from the 6 o'clock position, the opposite end. And keeping that air in the anterior chamber, we continued with our dissection. So it's a manual dissection. After completing the manual dissection, you can see the large break. So we put our suture. The first suture, we also take a bite through the posterior layer because we want the 2 layers to oppose. And once this is closed, we put a large air bubble in the anterior chamber, continue with our suturing. And at the end, we replace the first suture that included the posterior layer because that will induce folds. And then you do an inferior PI, and you can dilate the pupil, keep a large air bubble. And that's what the patient looked the next day. You can see these folds. Luckily for me, the perforation was superior, so the air bubble will tamponade it better. If it was inferior, I would have been in more trouble. And you can see I've kept my pupil dilated, the cornea is clear. You see some of these folds, and these folds are because of the first suture that I took, it created the folds. And these folds usually, maybe it will go away with time. I didn't want to go back into the interface and try to remove the folds because the apposition, what had happened here, it would separate, and then again it would be a problem to put it back. So if you have a large perforation, you don't need to worry. You always need to try. You may have to go back post-op and maybe inject some more air if there is a double chamber, but it is something that can be manageable. That's why it's important when you do a pachymetry, don't just look inferiorly, you have to see all the way around. Sometimes the thinnest point need not be inferior, it may be somewhere superior as well, because keratoconus need not always have inferior thinning. So sometimes when you have this kind of situation where you inject air, you can only get emphysema. These are very old videos, so that's why the quality is not as good as the recent ones. So if you have this kind of situation, you would go and you would remove the anterior stroma and then try to go back with your needle. And here I have put, the air has gone into the anterior chamber, so obviously I have perforated. So I go back to the same technique. I go and make a small pocket in the periphery. If you don't have the stromal spreader, you can use a pair of blunt tip scissors. And you can put the scissors in the pocket and you can dissect. And once you have done the pocket, then you can use your left hand to do the peeling. So you can see that the left hand is kind of, I'm just assisting the peeling. You come to that point and you can actually peel off the stromal tissue and put in your graft and suture. So that small perforation with the needle that I have had it's something because the stromal tissue is still intact, rest of the decimus is in place, you don't get a double anterior chamber in this situation. And that's the patient. So you can't, one eye I've done a big bubble DALK for her, the other eye she had the perforation where I did a manual DALK, and between the two eyes she prefers the eye where I have done the manual DALK. Because that eye, the visual output, the refractive error is less, so she will always come and tell me, you did a better job for me in this eye, not the other eye. And I would think that if you knew what the surgery was, then only you will understand. So instead of the needle, we use the cannula to prevent the complications arising of the needle. This we already spoke about, that a situation where you overinflate and you end up with a perforation like that. So if you have resistance, like in this case, I have put in air, but the resistance is felt, so I bared the predecimus layer only in this part. The remaining part in the periphery, you can trim down. The trimming down need not be always that you don't have to go below the residual stroma and cut it. You can trim it down vertically. That means you hold with the forceps and you hold your scissors horizontally and trim it around, so that even if you leave behind a small rim in the periphery, it's to your advantage, because when you are suturing, you can rest your needle on this stromal tissue and suture, rather than if it's predecimus, sometimes an accidental movement of the needle can puncture. Okay, this is already shown. This is the same rupture. Okay, now let's look at this video. This was during one of the courses that I was running and everybody was watching. You can see what happened when I removed my cannula, some of the air came out. I said, okay, let me put a small bubble test. So I put the bubble and I realized that the center was still, there was some air. So I said, let me go and do the brave slash. So what happened during the manipulation, the remaining air also leaked out and I went through and through. So I went into the AC and this was, so all the people who were observing, they said, this is over, now you have to do a PKP. And I couldn't give up, it's a question of pride. So I said, okay. So I said, let's suture this. So this suture is not a through and through suture. This is a suture only through the stroma. So I said I need time to think. So I said let's put I put the suture, put an air bubble in the anterior chamber. I went back to the periphery, started dissecting, and I entered into the space that I created with the bubble. So I then removed the stroma. So you still have a perforation there. So I didn't try to fill visco or anything. I put my donor tissue into place and I secured this with suture. And you can see that's the patient the next day. You can see the break there. And this is first day and this is by the third day. You can see the cornea looks very clear. So when you have a break, when you have a break, don't feel tempted to put viscoelastic into the anterior chamber. If you put viscoelastic, what will happen is the viscoelastic will try to come out through the break, and sometimes it will enlarge the opening that you have created. Even the air, I did not put the air before. What I did was I first sutured, I closed it, I put an air bubble, and not a very tight air fill, just a small air bubble to prevent the aqueous from continuously seeping out. I went back to the periphery and I did not disturb the central stroma till the very end. Once I have cut all the way around, then I remove the stroma. When I remove the stroma, the aqueous leaks out. Doesn't matter, your decimus may actually fall onto the iris, doesn't matter, it doesn't kill endothelial cells. What you do is first you put in your graft, secure with 4 sutures, and then if you go and put your air bubble, it will lift up the decimus and it will tamponade the break also very well. So sometimes in our hurry we try to put something in the anterior chamber, the break enlarges, and then it can make a mess out of it. So if you have a break, take a break. So if you don't feel agitated, don't you have a break, you said, okay, no problem. You can always sit back, relax, and plan. You have to see, I had a break, what am I going to do next? Do I have all the instruments that I need to manage this? Or because it's good if you think and you plan. Otherwise, in a hurry, you try to do something, you can make a mess out of it. And the first tendency would be, okay, this happened, let's convert. So for me, conversion is something that I may not want even to do. I will always try all the tricks to try and see to it that this does not happen. So that's why for deflation, put viscoelastic, and then you can do that. Let me show you another, okay. So this is again something that you tend to feel like, you're a perfectionist and you do that and you see some residual stroma in the periphery and you say, no, I need to remove that. And then you say, oh God. So if you do have this, Sometimes if it's a very soft eye and you really pull up the tissue too much and you take a large bite, so this is very common. So don't try to take too large a bite at one go. Always make small snips. Usually what happens is when you try to catch a lot of tissue, you don't see what you are cutting, and you can, so if you take smaller bites, you can actually see. And always, for me, I keep my eye soft. I use the left hand to lift up the residual stromal tissue. I put my lower blade in and I want to see where my blade has gone. I don't just blindly put it in and try to cut it, because if the eye is very soft, when you pull, the decimates can get pulled into your scissors, and if you cut it, you will create a break. So that's a patient who had a break, and you can see that when you see in diffuse light, this is looking clear. This part is edematous. So this is a DM detachment which is not too far separated. When you call planar, non-planar, this is more like a planar detachment, and this part is still attached. So in this case, we did not do anything, we just observed. And you can see over a period of time, it's spontaneously attached. So for me, if I have a detachment where some part of the cornea is clear, I will not rush in to put an air bubble. I will just observe. The attached part of the DM, as the endothelial pump starts working, it'll, like a zipper action, it'll pull up the remaining and it'll close it. And this is, unless you have left some viscoelastic in the interface, but otherwise, usually this will close. So I would wait and I would observe. So this is what I do for the peripheral tissue that's left behind. You can go with a scissor and you can just, again, you can see it's small bites. I'm not trying to take a very large bite with, so you lift up the tissue, see the stromal tissue, and you can cut it, so you can trim it down all the way around. Somebody was asking about use of cyclodialysis spatula so this is something I used to do long back. I used to put it under that, and you can see why I don't do it anymore. Because you try to think that whether it's complete separation or not, let me go and see, and you're happily moving it. Some part when you move, it's in your dominant area. Some areas it's non-dominant. So if you put it in that, you don't know how much of pressure you're applying, and you can end up perforating like that. And the problem for me was this was a medical student. So when I saw him the next day, so what I did in this case was I had the perforation, so I left behind a sliver of stromal tissue over the site of perforation so that it will tamponade the break. I did not remove the stromal tissue completely, and we put in the graft and we secured it in place. So that's how we can peel the tissue. It happens sometimes it does not, so then we use a dry Merosol sponge to scrape off all the decimates. So we secured this in place, and next day when I saw this patient, you can see the cornea was looking diffusely edematous. There's a separation that's going all the way around. I tried to convince the patient that maybe let's wait for a couple of days, and being a medical student, he was very much aware. So he was kind of after my life, no, this is, I can't see anything, and you promised me before surgery that next day I'll be able to see like 624 or something like that, and here I can't see anything. So I said, okay, then we went ahead, we did a rebubbling for him, and you can see that the next day he was looking good, so he was satisfied and he was happy. So you don't always need to use SF6 or C3F8 for this kind of situation. Air is fairly adequate. Just make sure that you keep your pupil dilated and don't end up with a pupillary block. So this is something where I got a mixed bubble. Let me just play the video again so you can see that I'm injecting air. You see the first bubble form, and then you see the second one. So the first one is up to here. The second one is, so that's the type 2 bubble. This is the type 1 bubble. So I saw that, I recognized it. I did a paracentesis. Now I'm trying to do a manual DALK. So I've done the peripheral groove, and the central part I peeled it off. So now this is the end of surgery, but I still have a large bubble, that's the type 2 bubble still present. So I put air in the anterior chamber, and then I just make a small nick to release air from the type 2 bubble. So I don't try to expose the type 2 bubble. Even if I did not release air from that, and if I just put my graft, that air would gradually get absorbed and the layer will oppose. But obviously you don't want the layer to be touching the iris. So that's why we make a small nick, but you have to just make a careful nick just to release air from the type 2 bubble. So this is again another case where we inject air, and you can see that you see this type 2 bubble forming. So previously so ignorance is bliss, when previously we did not know about type 1, type 2, any bubble forms, you're happy. You want to go and you want to open it up, and And if you have a complication, you just think it's your bad luck that day. So this patient had a type 2 bubble, so we decided to do a manual dissection. So again, making the peripheral groove, we completed his dissection. In the apex, you can see, so once we remove the tissue at the apex, you will see that it starts to weep. There is fluid that's coming out from the apex. And if I show you the pre-op picture, you will know why this happened. Because that time, the concept of choosing cases for big bubble was not there. This was a patient with a hydrop scar, and I was happily trying to do a big bubble. So you can see that, so that's why you had the complication. But this patient, after the DALK, did fairly well. You can see that's his post-op. He was up to 618. He was still very happy, thought that I did a very good surgery and a great job. So this is what happens when you have a scar and you still want to do a big bubble. You inject air, the scar ruptures, and you get this air into the anterior chamber. So you don't need to convert. You can still go ahead and do a manual dissection in this situation, because usually the perforation that you have is a very small perforation, and if you keep the stromal layer on top intact, you don't get a double anterior chamber. So the endpoint for this dissection in these cases, so you can see that if you don't have the stromal spreader, you just use a fine scissors, and you can introduce the scissor in the pocket, and as you open up the scissors, you can create, just that the direction of the tip has to be horizontal. You don't, because it's, as you go more and more deeper, your posterior layer is very thin, and if you're not very careful, you can easily perforate with the tip of your scissors. That's why anterior segment is OCT, to recognize scars. This is again, I managed to find the photograph, but I've never managed to find the videos in my huge collection of videos. So I still am trying to search for this video. So this is a patient who has a type 2 bubble, and these 3 small bubbles are in the anterior chamber. And when you make a small nick to release air from this type 2 bubble, you can see all these small bubbles, they come back to the center. Okay, this is again a very old video. This is a type 2 bubble that formed there. I was unaware of type 2 bubble, so I am happily dissecting, and I said, I got a bubble, very nice. Let's do the inverse technique of surgery. So I open it up, and I'm happily splitting it up into 4 quadrants. You see this blue mark? I'll tell you why I make that blue mark. So what you're seeing here, that's the predecimus layer. This is the layer that Dua described, and this was maybe in 2001 that I was using it. When I showed it to Dua, he says, my God, you saw the layer then. I said, I never knew that was a layer. So I was, now watch what happens. So you see that? I was concentrating more on cutting that layer, and I was thinking to myself that the decimus is looking so nice and shiny. This is the best surgery I have. And before I knew, and it's not a sharp tip of the scissor, it's a blunt tip, and I just touched, and before I knew, I got a rupture that went from here to here. So there's no way I can recover from that. So this was a big shock. So this is the macular dystrophy that I showed yesterday, where you inject air. The bubble was not reaching up to this part, so I kept on injecting to try and make it reach there. And then I said, okay, give me the paracentesis, and I was concentrating here. And once I did the paracentesis, it came out, and I saw this huge rupture, and I said, when did that happen? So I always had to go back and play the video, then I could make out that. So this is again overinflation of the bubble. So this is just to show you that you got a bubble, you felt tight, I made a paracentesis, now I go back with my cannula into the same track, and you inject air, and in a very controlled manner, you can enlarge the bubble to your desired size. So that's again a very interesting case. This is a case of pellucid. And this patient with pellucid, somebody has already done cataract surgery for him. So you see that that's the cataract surgery wound. And obviously in a pellucid, if you do cataract surgery and put a monofocal lens, the patient is not going to improve. So everything was done, and then he was referred to me for corneal surgery. So cataract surgeons in India, they don't like corneal surgeons. So Fuchs dystrophy, they will call up and say, I have a patient with Fuchs dystrophy. I will do the cataract. If something goes wrong, you manage the cornea. But they will not send the patient for a combined cornea. And the same thing for pellucid, they will first try their luck. Cataract they will do the cataract, and then they will send the patient over that, okay, now you can. So this patient had a cell count of only about 900. So I was looking at that and contemplating what am I going to do. So this patient also, we did the same, we did the same technique what I showed yesterday. We did a peritomy, we did an eccentric trephination, I removed the anterior lamella, and then again if you see, we create a bubble and the bubble ruptures. So just my day. Huh? And if you see, it's not a small rupture. It's actually it's quite a big rupture. It's about this big. And I said, oh God, this is ruptured now. Now it's cell count of 900. What do I do? And such a large PKP, I have to do such a big graft and going all the way up to limbus, and then I have to go and tell him about immunosuppression and everything. It's a really bad day. So I said, no, let's not convert. So we went ahead. I was just thinking to myself, and I managed to find the plane that we created with the bubble. I gently removed the tissue. There is a break here. I put in my graft, did an inferior PI, put a large air bubble, and I said, we'll see tomorrow how to deal with the patient. Next day I see the patient is very happy. So you have a break that's here. This is not the next day, this is a month later when he came back for follow-up. You can see that that's the break there, but the cornea looks pretty clear. This is the break. If you see that between that point and this point is the break that I had. So even with such a large break, doing a complete air fill, you can still manage detachments like that. If you see here, that's the residual stroma. It is between this point and this point that we bared the pre-Decimus layer with the bubble. This is again an interesting case. This is a 6-year-old girl. She had a squint surgery done elsewhere. Post-squint surgery, she developed a Dellen, which got infected. She developed an ulcer, which was treated. The ulcer also had a perforation. And when she came to me, she had a very diffuse thinning of the cornea going all the way up to the limbus and with the scar. And I was thinking to myself, how do we deal with this? Because if I have to do a PKP, it will be very close to the limbus at one edge. It will be a very large graft. And in a 6-year-old, the risk of rejection is very high. Discussed with the parents, and I said, we'll try a DALK. So parents were a little skeptical. They think everybody said PK is telling DALK. So I went ahead, tried my luck, and as I was dissecting manually, when it came to the point where there was a perforation, as I was stretching the tissue, suddenly I found that the whole tissue came off on its own. So I had a gaping hole there, maybe measuring about 2.5 to 1.5 millimeters, something like that. And then I said, okay, what to do now? So I put my graft there, and I put air, and as long as the air was there, it kind of seemed to remain in place. So I prayed to myself and I said, let it remain like this. Patient went back to their hometown, and patient came back a month later, very agitated, and they said, no, you did not do a great job. I thought I'll get sued in court. So they said, we went to our local ophthalmologist, and my local ophthalmologist scolded me, saying that why did they do a lamellar graft? They should have done a PKP. Now see what has happened. And they were so agitated when they came into my room, and I saw and I said, yes. But then I tried to explain that tectonically your graft was very thin, and if I had to do a PKP, very large graft, even if this does not work, I can always go back and do a smaller graft in the center, but they were not willing to listen to anything. So I took the child up for EUA the next day, and I was still thinking what to do. I thought maybe rebubbling. So now when I put air, what happens is the air goes into the anterior chamber, and then it comes into the interface through the hole. So you inject, because it's become a little tight, you inject air, the air comes, so there's no way the air remains in the anterior chamber. So I said, what to do? I said, okay, nurse, give me the suture. And I put full thickness suture, one vertically, one horizontally, to oppose the layer at the site of break. I said, what is the worst possible thing that can happen? Maybe I'll kill some endothelial cells. If not, anyway, I have to do a PKP. And once I did that and I put an air bubble, the air bubble remained in the anterior chamber. It did not come out. So then I saw the patient, and when I saw the patient the next day, you can see that the cornea, this part is already beginning to clear. So I told the parents, I showed them photographs and said, between this and this, see, is already, so they were kind of a little convinced that it's looking fine. She went back, 1 month later, we removed the sutures. Those are the suture marks which are left behind. This is now about 5 years, C612, with anti-amblyopia therapy. So now the parents are very happy. They said, you did the right thing because she's not on any steroids. So what I'm saying is, you may be faced with difficult situations, but lamellar keratoplasty is something that you should use for your patients because it really benefits in the long run. So you see patients with loose sutures that come like that. They don't come when it's in the periphery, but when it starts involving the visual axis, that is the time when they rush to you. So this patient also had loose sutures. The sutures have been removed in this photograph, so you don't see that. There was some amount of a corneal melt and something like a stromal rejection because of the loose sutures. So I had to actually, in this patient, I had to go back and redo the DALK. There are patients like this with lipid keratopathy. They wait till the visual axis is involved. They don't come to you. It's only when the keratopathy starts involving visual axis that they decide to pay a visit. So this is like 4 years after DALK, they just land up in your clinic to say, I'm not seeing well. So you take him out, I took her up for surgery and trephining. You can see, because it's in your mind, you're thinking, okay, what am I saying? Again, I perforate. So I've got a through and through perforation at 6 o'clock. Because I was trying to go deep because I have to remove the previous graft. So put a suture there, put an air bubble. So now I'm dissecting in the periphery, trying to reach the plane between the original graft. But because of the lipid keratopathy, sometimes adhesions is a little more, it doesn't separate. So I said, okay, let's do a debulking. We finished the debulking, and once we have done the debulking, we see that in the periphery, you can see the original space. So then you can go and you can, a Sinskey hook is a very good device, Sometimes I use the Sinskey hook quite commonly, even if I have to search for a stromal pocket or anything like that. So that's the previous old fold in the decimates. So I was able to put another graft and put the sutures, put an air bubble in the anterior chamber, dilate the pupil. So this was how the dilated pupil, air bubble, she was looking the next day, and then maybe a week later, and as would have it, after a week, I have not seen her till today.
I have a case like this, but with the perforation at the center. So maybe
if
we
the
go
surrounding
more superficial.
Yeah.
Just
Perforation
leave the
is
scar, some scar on the visual axis. Because I could not remove the whole thing, it may make the perforation larger.
If it's exactly in the visual axis and you feel that's going to affect the vision, then maybe you'll have to think about doing, because if the scar remains in the visual axis, it's going to affect. In my patient, it was not exactly in the center. So that is a decision you need to take clinically. But if the endothelium is healthy, you can always try giving a chance by putting a full thickness suture to try and oppose and then look at it. So in this patient, as would have it, after this, I have not seen her because most likely her vision has got better and maybe she just refused to come back for a follow-up. The stromal rejection very frequently will look like adenoviral. When you see your patient with DALK, you will see these nubular opacities and they will be usually just within the graft. So I think that is again when you see, because a lot of time we see this patient and we say, oh, you got adenoviral, but that's not actually adenoviral, that's an early stromal rejection. So pre-op evaluation, again, is very important. Microperforation or perforations can be managed. A second procedure may be necessary to reattach the DM. If you have a macro perforation, sometimes a very large one, you may have to convert to a PKP. And suture management is essential to prevent post-op complications. So that's about...
in which kind of case that you put SF6 for reblubbing? Or you don't use it at all?
I have never used SF6 till date, but yes, if you have a retina practice in your clinic and you have access to SF6, if you want to have a long-term tamponade, putting a non-expansile mixture of SF6 along with the inferior PI is a good option. Because air, what happens is very unpredictable. In some patients, the air bubble will remain for 4 days. In some patients, you put an air bubble and sometimes in 2 days, the air bubble is reduced. So you don't get adequate tamponade sometimes if you want. But again, gas and endothelial cells don't seem to go very well, so you have to take that also into account. Once the job is done, do you want to keep unnecessarily the air for a very long period of time?
Do you have your videos on the pellucid that had a full, how do you say it, full diameter graft with the rim of sclera?
Oh yeah, I'll just look for it and
we would like to see that.
I'm sure it'll be there.
Okay, Rajesh, just learned that the anesthesiologist appointed us to have the live surgery
Okay.
at 10. So maybe we can keep that for.
Sure, I'll by the time I locate the
Yeah,
video
yes,
and I
yes.
can show it
Okay.
to you.
All right.